my time, hopefully wisely, to kind of give you a little bit of overview on the future of robotics in spine care in the next 10 minutes and for the foreseeable discussion. And I'm looking forward to the questions in this context. And I'll try to kind of reach a little bit further away so that kind of also the potential application that are maybe not yet established in the field become at least parts of our thoughts. So it's always a great pleasure for me to talk in front of medical doctors, because obviously this bridge is very important, especially for us technologists. I was hearing a lot about discussions on robots and AI possibly taking over. So I think it's very important that there is a tight bridge to kind of come to this future of AI and robotics really supporting us in the daily care, daily medical treatment, and really as a kind of a service, as a tool to the medical staff, in a sense that it really kind of relieves from burdens and gives new abilities. And I think this is very interesting, especially with the recent rise in robotics and in particular also AI, so perception and making use of data, and then obviously kind of closing the sense plan act loop as a potential tool for various applications. I think it's very well known, obviously, in this esteemed circle that the surgical robotics development has tremendously progressed over the recent years. It kind of, in a way, started with the Da Vinci system really becoming the state of the art in various kind of application domains, in particular in urology, and then also later on going to surgery, cardiothoracics, and so on. So what is kind of interesting is this idea of giving a doctor a tool that is able to kind of operate remotely via kind of a pretty big robotic system, but with very cleverly designed end effector tools, and then giving the impression of an avatar, one could say. So bringing the skills of the doctor to a remote location that he is not physically at. So very related to the talk we saw before in terms of telemedicine, one could say, but with physical remote possibilities on site, in this particular example, in the body. And obviously surgical robotics have also entered neurosurgery with various procedures in DBS and SEEK. And in particular, these so-called position-controlled devices were so far mainly used for navigation tasks, for so-called position-controlled operations. So no feedback of the haptic sense of touch to the surgeon so far. But over the last years, various hundreds of thousands of patients being treated in various applications ranging up to radiosurgery. So what is kind of interesting is in particular the idea that not only the robot, the physical object, but also the registration and the sensory setup on site are supposed to support, for example, I heard something about the pedicle placement, I think 2 or 3 talks before, where in particular the robot is essentially kind of a flexible tool that you can position in order to support you with a kind of a very strict positioning constraint, so that the surgeon is really empowered to kind of use his dexterity, his sensitivity, but the nice navigation properties and stiffness of the system to really place the particular objects in the body. And these kind of systems have become kind of reasonable and standard. However, they are in some form dependent compared to industrial robotics for the classical industrial robotics in car manufacturing. So very strong position control devices, not yet tactile sensation. So the interaction with the physical body is still limited and not yet displayed to the surgeon. In particular, another kind of rather recent direction in surgical robotics is what happens if we come into curved and in particular unreachable situations. Then obviously we need to think about fundamentally new ways of designing robots. So the mechanical systems, so one could say the body of the artificial intelligence of that kind that is able to kind of sneak around the cavitations in the human body and really be able to explore in a way, in a safe, however dexterous way, and obviously into the smallest ways possible. So these so-called continuum robots are in some form, one could say, the next generation of endoscopy snake-like systems that are typically controlled via what we call bioinspired control systems. So the idea is to have remote actuation, which makes it possible to really have very small and delicate structures exploring the human body and giving a kind of a new way of really having a continuous or continuum avatar in the system. in the human body for the doctor. Various systems have been designed up to the smallest scale, so really orders of magnitude smaller than typical surgical robotic systems. We heard also about the Verb Surgical as the kind of unification of Google and Johnson & Johnson that try to kind of make surgical robotics available and affordable. I think it's very clear that the miniaturization and the kind of new way of designing robots in a much more bio-inspired way that are compatible to the human body seems to be the very direct next extension, and giving robots a new way to explore not only the human body, but also place novel types of sensation and giving feedback to the surgeon at hand. So very different applications can be thought of. Here we can see in a form that the end effector has some functionality. So in this particular example, it's an optic catheter with a directional fiber, so we can essentially have controlled thermal energy at the particular site where we want to implement it. So it's not always about getting feedback, but also about getting the treatment there. And then obviously you could also apply MR thermal imaging with this novel kinds of ideas like LIT, laser interstitial thermal therapy, which we see here. And then obviously over the next years to come, there has been new prototypes that kind of bring also two hands into the body. So not only various robots coming from different sides, but actually having kind of multi-port systems that are able to really give a miniaturized representation of the surgeon into the body and give them the feedback to the system. And there's this kind of evolving further and further into the field of what we call nanorobots, medical nanorobots, where small capsules can be basically brought through the body, typically at the moment still externally controlled via electrical or magneto-electrical fields, and however thought to be self-propelled over the course of action. So with these kind of thoughts, it's very clear that with the next generation of robots, in particular with an artificial sense of touch, we can think about new types of systems that do not only give you visual feedback or are able to steer around the body, but in particular with an artificial sense of touch that is typically being realized by what we call strain gauges or optical technology to then display the forces that are felt in the body, plus certain model-based control and AI algorithms, to then have robots that can be taken by the hand that really have a sense of touch, that are able to essentially render human interaction, human safety, and in particular the human neuromotor control system to then be able to be safely interacting with potentially fragile objects with the sense of touch, and really being therefore also a tactile feedback system if you want to use it for a similar application as we see with the classical surgical systems. So with these systems, regardless of the environment, whether it's spongy, whether it's very rigid, the robots are able to show and render very high performance force rendering. So the tactile sense of touch is in fact much more kind of reliable and repetitive compared to human sense of touch, obviously. So higher quality and higher monitoring of the particular operation could be done in principle. Still, however, mainly in the lab and not yet have reached the operation room. Another important aspect, if we think about the future of robotics, is how do the human models, the kind of not the static visualizations, but really the human models into the kind of thought of the robot, how can they make use of this? So the human visualization obviously has made tremendous progress over the last 3 years, coming up to the kinematic renderings where we can really see almost at kind of visual video level really into the human body. However, this is not yet the functionality, so the functionality has to be coupled with the robot. And for this, we need to understand in a real-time fashion, giving external sensing, how does the internal neuromechanics or other internal body functions interact. How do they kind of change over time? The internal functionalities, the forces, the chemical process, and so on have to be rendered in real time in order to then be able to understand not only the control principles of the human internal, to then design systems that can be compatible with that, but really be able to also kind of understand in some form the programming of the human neuromotor control system, for example, to then bring that kind of understanding of the human dynamics, kinematics, but in particular control principles, such that they can be used to program essentially virtual humans, one could say, to not only do motions, but to actually produce the forces, the interactions that really are necessary to drive the human body in a sense. So it could be kind of the motors of the human body really being well understood, and then make out of the body a robot that basically can be programmed to then finally not only have this for the upper body, but also for the legs, and then really make intelligent exoskeletons, for example, that then can make use of this kind of neuromechanical models of the human to make model-based control, to give assist as needed in various applications, and really with this understanding of the human body, make the robot understand what the right treatment in an adaptive and kind of intelligent fashion could be, to then really be of a better assistant to the particular human need. Obviously, there's many applications in this direction. The last one I just want to point towards is so-called brain-machine interfacing, which I think it's very clear, especially with the recent kind of announcement from Neuralink of Elon Musk that you might have seen, where the idea is to not only interface the human brain, the spine, or other kind of parts of the neural system, but then also use these neuromechanical models and the understanding of the human body to then be able to control complex robotic or assistive devices with the understanding of the human, not only brain, but also with the motion mechanics and the neuromechanics, then be able to connect brain-machine interfacing with robotic devices, and then be able, this is a very famous video kind of almost 10 years ago, which we did together with John Donoghue at Brown University, which was the first continuously controlled robot arm. And the lady we see here in the image was able to control just with up to 10 neurons that were directly interfaced a 19 degrees of freedom robot system just by thought and in a continuous fashion. So really, she thought in some sense this is her arm. These experiments are currently for the next years are being recreated again in our labs and obviously on larger scale. But the idea was really to fuse robotics, AI perception, plus the understanding of the human body to really bridge the gap between these kind of the embodiment of the human itself, the robot as the potential avatar of the human, obviously in the context of neural control, telemedicine, and rehabilitation. This is kind of the key technology that really might be a game changer in that respect. So I would like to thank not only ASI for having invited me, but also would like to take the chance to thank all the generous support that we received over the years for our funding. And yeah, thanks a lot for your attention, and I'm looking forward to the discussions and questions. Thanks.
Thanks, Dr. Sami, for this mind-boggling presentation. I think what you spoke in 10 minutes would take us at least one day to basically understand what you're talking. It's so much of information and so much of knowledge at the moment. So I would welcome questions, because I believe there will be a lot of questions. So we are a little short of time. Questions from the audience? I think all are spellbound.
Dr. Sami, you had mentioned about the application of robots, but they are more towards neurosurgery. When it comes to the spine, when do you think will we have a proper application in the cervical spine? It will take time because you are not able to control the movement there, and right now the robots available are not approved for use in cervical spine.
Well, I think there is a fundamental technology gap that we are still facing in a way. So thanks for this question. Because I think it's very clear that we need very flexible and dexterous systems. So this idea of continuum robotics that I was showing, I guess there is still a lot of development that has to be done there. And then there is also the important aspect about online navigation. So in order to really have robots being able to be as dexterous and flexible in the cervical spine, I think it's very important that the registration and the online navigation, similar almost like an autonomous car, one could argue, have to tightly integrate with each other to really be of a very precise and also dexterous system at hand. So I think this will still take several years to get to that level that it really becomes clinically widely used. So there are still very basic questions to be asked. In comparison, one must admit, to the rather classical way of surgical robots. Yeah, indeed.
Bhavuk informs us that the Globus Robo is approved for cervical use as well, but I'm not sure if Bhavuk has used it in the cervical spine, because even say when you use it in the thoracolumbar spine, because with the slightest of movement, the registration may get affected, and you may not have the precision per se.
It's
to be honest,
actually the cervical instrumentation is quite different, and they have different instruments for this. We are just in the process of purchasing that. Dr. Sajan Hegde, as far as I know, probably he has those cervical instruments.
Dr. Sajan would like to comment? No.
I'm not sure if he's there. Sami, you were saying something?
Well, I think I just wanted to support what you were saying. I mean, of course, it's always possible to kind of design very specific applications. But if we think about what you just said about the registration process, in order to get to intelligent robots, and not only, I mean, a robot, if it's just a tool in a way that is barely a kind of a positioning device, then it's still at the bridge between being a pure machine or a mirror machine and an actual robot that really has a certain level of autonomy. So I think this is kind of the question also on the definition level. So I think it's as always, the more flexibility you want, the more advanced, but also the safer the technology needs to be. So, and I really think that this combination of imaging, model-based complementation of kind of human models and the tight interaction with the robot are really vital, because we have seen over the last 20, 30 years in various applications that these kind of limitations have already been creating various problems also in spine surgery, right, in all the clinical applications we see so far.
Dr. Drazen wanted to make a point on robotic use. Please go ahead, Dr. Drazen. Dr. Daniel Drazen, you wanted to make a point? Yeah.
Yeah, sorry about that. I'm still starting my video. I would just say that in the cervical spine, yeah, the Globus robot is used regularly. For Mazor, it is off-label currently just because of the mobility in the cervical spine. They are working on trying to get that sort of proven as an exemption. And so I think that's sort of a futuristic possibility.
But you have, it is being used in the cervical spine with precision and, right.
Yeah, I've used it for the Globus, mostly for like C7 pedicle screws and a C2 screw, but most of that stuff I just use freehand, but I have used the Globus robot for the cervical spine. Haven't had any issues. I've had issues in the thoracic spine with that robot a few times.
And no issues with deformity use where the anatomy gets changed and you have, for example, in a kyphotic deformity, registration sometimes becomes a challenge.
Yes, exactly. The registration becomes a problem mostly for the obese patients and patients who have severe deformity. And those are the patients that you have to decide whether to continue using the robot or to kick it out, which I've done on occasion.
So thanks, Doctor. Thanks, Sami, joining us. And we heard you also during Spine 20. And I thought we can have the ASSI members listen to your mind-boggling talk. Thanks, and we'll look forward to long-term collaboration and having you again and again. With that, we will move forward to Dr. Daniel Drazen. He'll talk on potential of big data, computer vision, artificial intelligence, and machine learning in spine care.